Hi, I welcome all the viewers, physiotherapy students and physiotherapy professionals for this presentation. I am Shweta Ramesh, student of final year physiotherapy, here to make a presentation on the topic Role of Physiotherapist in On-Field Injury, Assessment and Management. Before entering to the topic sports injury, I would like to say something regarding the relation between sports and physiotherapy. Physiotherapy has a vital role in the sports player's life and health, starting from the physical fitness, training, till the rehabilitation of an injured player. But in this presentation, I am focusing on the on-field injury assessment and the immediate management. Now, to the interaction of sports injury. Sports injury is an injury to a player during an athletic activity or during a physical exertion, which may result from acute trauma or repetitive stress. Incidents of sports injuries show that among on-field injuries, minor soft tissue injuries are most common, accounting about 95% of total on-field injury. And among the soft tissue injuries, sprains and strains have the more incidence rate, followed by fracture as the second most common on-field injury, and contusion and abrasion, the other common injuries which are minor in nature. Next slide explains about the classification of sports injury. Sports injury is classified into two categories based on the cause and the type of tissue involved. According to the cause, it is classified as direct, indirect, and overuse injury. And according to the tissue involved, it is classified as soft tissue injury and hard tissue injury. There are three types of tissue in human body: the soft tissue, hard tissue, and special tissue. Soft tissues include muscles, ligaments, tendons, skin, fascia, and fibrocartilage, whereas the hard tissue includes bones, joints, and articular cartilage. Now, we are going to see in detail about each sports injury separately, starting with sports injury according to the cause. Direct injury, injury that occurs due to an external force during the activity. For example, collision with a co-player or a bat can result in fracture or dislocation. Indirect injury, injury caused due to an internal force, that is the force created within the player during the sports activity due to poor technique or overstretching. Example is improper landing after a jump can result in ankle sprain. Overuse injury occurs when there is excessive or repetitive force given to a bone or other connective tissue, which can result in inflammation, irritation of soft tissue, or cracks in bone. Initially, little or no pain is administered, but on continuing the activity, it will aggravate the pain, which is common in sign. One of the example of overuse injury is stress fracture. Next to injuries according to the tissue involved. Soft tissue injury, which involves the injury to soft tissue, that is, injury to any part of the body except bones and teeth. Some of the examples of soft tissue injury is contusion, ankle sprain, and hamstring strain. Hard tissue injuries are injuries to the bone, which is usually less frequent than soft tissue injury, but are more serious than them. For example, hip dislocation and finger fractures. Next slide is about the causes of sports injury. Causes are classified into two categories based on the intrinsic and the extrinsic factors. Intrinsic factors are within the player's body, that is, an individual's anatomical, physiological, biomechanical, or pathological characteristics. Intrinsic factors that causes injury during an athletic activities are misalignment of the body, laxity of the joint, muscle fatigue, muscle imbalance, hypoflexibility or hyperflexibility, which can result in change in the normal biomechanics of a player, which is the main cause for an on-field injury. Other intrinsic factors for the injury can be age, lack of nutrition, changes in hormonal levels, or due to any pre-existing injury. Whereas the extrinsic factors are outside the player's body, that is, the environmental factors like change in playing surface, uneven surface, playing in too hard or too soft surface, sudden increase in frequency, intensity, or duration of training. Some of the other extrinsic causes like improper footwear, incorrect technique of sports, and inadequate warm-up or cool-down can also result in serious on-field injury. Here are some of the common sports injuries which are grouped according to the specific sports. Among the below mentioned sports, football has the highest rate of injury incidence. Here are some of the list, starting from ankle sprain, hamstring strain, muscle pull, shin splint, jumper's knee, Achilles tendinitis, turf toe, concussion. Ankle sprain usually occur due to improper footwear and during ankle strains. Hamstring strain is due to repetitive stress and without proper warm-up. Muscle pull. Muscle pull is common in hamstring, quadriceps, and calf, which is due to overstretching of the muscle during the physical activity. Then coming to the shin splint. It may occur due to the change in activity or excessive running. Jumper's knee is common in football players, which is due to overuse. Achilles tendinitis. It is degeneration of Achilles tendon, which leads to the inflammation of the tendon. Next to the knee ligament injury, which may cause due to sudden change in direction while running. Then turf toe, which occurs due to repetitive pushing of big toe forcefully. And concussion. Concussion is traumatic brain injury, which is very common in football, which accounting about 75%. Now moving to the athletes. Athletes have runner's knee, which is very common, and Achilles tendon, which is also due to repetitive stress and inflammation of the tendon, and muscle pull in hamstring, quadriceps, calf, and groin, which is also due to overstretching of the muscle, and plantar fasciitis. Main complaint. The cause of plantar fasciitis is usually unknown, but may also be due to tight calf or high arch. Then coming the shin splints, IT band syndrome. IT band syndrome occur when the IT band rubs with the knee during running, which may cause inflammation. Then side stitch. It is muscle spasm of diaphragm, which is usually experienced over the lateral side after a strenuous exercise or running due to increase in abdominal pressure. Again, in athletics, turf toes are also common. Next to the cricket. In cricket, sports injury are classified according to the bowlers, batsmen, and the wicket keepers. In bowlers, rotator cuff injury, shoulder impingement, elbow injury, and hand fractures are common. And low back pain, ankle twist, hamstring strain, knee injury are also common, which also occurs in batsmen. In batsmen, calf injury, knee injury, cramps are very common due to prolonged standing and overuse of these muscles. Then for the wicketkeeper, groin injury and finger fracture is very common. Groin injury is due to overuse of the muscle or from overstretching. Next to the volleyball. In volleyball, jumper's knee, low back pain, ankle sprain, rotator cuff tendinitis. These are the common injuries in volleyball. Next, moving to the basketball. Basketball is similar to volleyball in which jumpers knee, turf toe, Achilles tendinitis, knee tendinitis, and ankle sprain, ACL tear are common. Next to the weightlifting. In weightlifters, cramps, blacking out, shoulder impingement are common. Blacking out is nothing but dehydration or restricted blood flow to the brain. And shoulder impingement syndrome occur due to repeated overhead activities, which causes inflammation of the rotator cuff. Then cramps, again for dehydration and compression of cough during the initial stage of lifting. Then comes the boxing. For boxing, concussion is very common due to a direct injury, rib fractures, and nose injuries. In boxing, the sports injuries are very fatal in nature. Assessment of on-field injury. The main aim of on-field assessment and management is to prevent major injuries and to provide primary care or immediate care to the injury. On-field assessment is divided into two parts as primary and secondary assessment. Primary assessment is done to ensure whether the player is in life-threatening condition or not. If the player is under any immediate threat, primary care should be provided and we should inform the emergency care. Primary assessment should be performed within minimum of 2 minutes and to maximum of 10 minutes. During this, the player is not advised to move if the player is conscious. If the player is intact in primary assessment, the therapist can proceed to the secondary assessment. Secondary assessment is usually done when the player is conscious and not under the immediate threat. The therapist can proceed to secondary assessment only when it is assured that there is no need of primary care. The secondary assessment helps to decide that a player can resume to sports or via a rapid head-to-toe physical examination. The first step in on-field assessment is to manage the threat of life of the player by the RABC procedure. This procedure is also known as primary survey, which helps the therapist to decide whether there is need to administrate the first aid or to call the emergency service. Elements of the RABC procedure are first with the stands for danger. The first element, danger, explains that the first step in primary survey is to ensure that the player is not in the dangerous situation. If yes, then the therapist should move the player from the place to prevent further injuries. Once it is confirmed that the place is safe for both therapist and the player, next element of the primary survey is carried out. The second element R stands for response from injured player. The response from the player is measured or assessed by AVPU scale, in which A indicates alert, that is, the player is moving or not. If the player is not moving, proceed with V. V indicates the voice or verbal. It is the response from the player for the therapist voice. The therapist should speak clearly and loudly to the player, and the player should respond by opening the eyes and seeing in the direction in which the voice is heard. Next is P, which stands for pain. If there is no response for verbal stimuli, the next step is to give a painful stimuli, for example, pinching the earlobe. If there is no signs of responsiveness for all this above AVP, proceed indicates the unresponsiveness. At this point, the patient is considered to be unresponsive. The next element in the RABC procedure is A, which stands for airway. Airway is assessed to check whether there is any obstruction so that it could cause obstruction in breathing. Obstruction can be due to falling back of tongue, which is common in sports injury, or due to any foreign objects. If there is any obstruction, the therapist needs to clear the airway. Airway clearance for falling back of tongue is done by positioning the patient in supine lying with head tilted back and opening the mouth by pushing the chin down using the fingertips. In case of obstruction due to any foreign objects, Heimlich maneuver is used. Heimlich maneuver is also called as abdominal thrust, which is a first-type procedure to clear an obstruction from windpipe by sudden strong pressure over the abdomen between the navel and the rib cage. This force lifts the diaphragm and expels air from the lungs, thereby causing the foreign object to be expelled out. Here I am showing a video on Heimlich maneuver.
Put one hand on top of the other. Okay? Now the reason this is good for if you're small and you're doing it on someone big is you don't have to reach around. You use the weight of your body to push down. Okay? Do that.
The next step after the clearance of airway is to check for normal breathing. Normal breathing should be examined for 10 seconds. Breathing is examined by feeling the breath on the chest, hearing the breath sound, and watching for chest movement as shown in this picture. If no signs of breathing, the therapist should inform the emergency service and start with the CPR. CPR, cardiopulmonary resuscitation, is a procedure which involves chest compression along with artificial ventilation to preserve intact brain function till further treatment is taken by means of restoring circulation and breathing. In this procedure for chest compression, the therapist should place the heel of the hand on the center of player's chest, then place the other hand on the top of the first hand, with shoulders placed straight above the hands and pressed down by 2 to 2.5 inches. 100 to 120 compressions per minute should be given, and for every 30 compressions, 2 rescue breathing, that is mouth to mouth or mouth to nose breathing, should be given. But if the breathing is normal, proceed to examination of circulation. C. Circulation is the last element of DRABC procedure. The player's circulation should be checked for 10 to 15 seconds. Circulation can be checked using carotid pulse. And another method to examine circulation is by checking the capillary refilling. Capillary refilling is assessed by squeezing the nail bed or hypothenar eminence. Normally, capillary refilling should occur in 2 seconds. After assessing all the elements in the RABC procedure, we can proceed to the next stage of assessment. It is not necessary to perform this procedure in soft tissue or hard tissue injury, but it is used mainly in case of sudden collapse of the player during the sports injury. Next is the TwoTabs assessment. The secondary assessment. TwoTabs assessment is the commonly used format of on-field sports injury, which helps the therapist to decide whether any treatment is needed or the player can resume to play sports activity. The first T in TwoTabs stands for talk. Initially, the therapist should talk to the player and ask what and where did the injury happen. And we should also ask about the pain characteristics to the player. Following T, O stands for observation. The therapist should compare the injured site and the normal side of the body and look for any swelling or deformity. The second T in TwoTabs stand for touch. It is very important to touch and assess the player. Touch and feel for tenderness, warmth, swelling or any deformity. Then ask the patient to move the injured part actively within the pain limit. This is the next step in TwoTabs that indicates A for active movement, followed by P, which stands for passive movement, in which the therapist should carefully try to move the injured part through full range of motion. Finally comes the S, skill test, in which the player is asked to stand, run, jump to show that they have the ability to perform the game skills. Only if none of the above procedure has resulted in pain. If severe pain is identified, remove the player from the activity and proceed with the treatment. But the above guidelines, that is the RABC procedure and TwoTabs assessment, is not applicable for assessment of head or spinal cord injury. The very important point to be noted before the assessment of head and spinal cord injury is to stabilize and immobilize the patient's head and cervical spine as given in this picture before starting the assessment. Next, moving to the head injury assessment. The assessment of head injury is done after a evident head injury in the player during on-field activity. First step is to call the emergency service, and then the head injury is assessed using neural watch chart till the emergency service arrives. This neural watch chart is done to monitor the player's vital sign. This assessment should be done for every 5 to 15 minutes, and after the player becomes stable. The recordings are done after every 15 to 30 minutes when the patient is stable. In the neural watch chart, there are 8 units, which include vital signs, consciousness, speech, awakened response, nonverbal response to pain, pupil reaction, ability to move, and finally the sensation. This recording helps to note the changes in patients over time. Now to the assessment for concussion. Concussion is traumatic brain injury caused by blow to the head during the sports activity, in which the player has temporary unconsciousness or confusion. All head injury need not be a concussion. Pocket concussion recognition tool is used in the assessment of concussion. Concussion in on-field injury is usually accompanied by fencing response. Fencing response is a peculiar position of the upper limb in which one limb is in extension and other limb is flexed. This response occurs due to moderate force to the midbrain, that is the brainstem, which lasts up to several seconds after the impact. Now to the assessment for spinal cord injury. Spinal cord injury can have serious and irreversible neurological consequences. So, early assessment and treatment is essential. In on-field injury, cervical spine injuries are more possible, followed a neck injury. So, cervical assessment should be done initially. On-field cervical injury assessment is done in both conscious and unconscious player without moving the player. In conscious player, the player is asked to stick out the tongue or squeeze the examiner's finger. These are done to know whether the player can hear and follow the instruction. If the player cannot follow the instruction, it is considered to be a cervical injury. In unconscious player, the therapist should apply a painful stimuli and watch for the spontaneous limb movement. If no movement is observed, it indicates severe cervical injury. Situation in which cervical spine injury must be suspected are neck pain or stiffness, cervical muscle spasm, asymmetric head position, respiratory difficulty, unconsciousness, numbness and tingling sensation, muscle paralysis, loss of bowel or bladder control. This slide explains about the assessment for bleeding. On-field assessment of bleeding or hemorrhage is done to prevent further damage or to prevent excessive blood loss. Each type of wound has specific bleeding characteristics. In laceration, external bleeding will be present. In contusion, internal bleeding is seen, whereas in abrasion, slow bleeding or oozing on the surface is clearly seen. Based on the characteristics of bleeding, treatment can be given to prevent further damage. In case of presence of CSF or blood in the ears or nose, it indicates the skull fracture. In bleeding condition, hemodynamic stability should be maintained to prevent further complications like stroke, by applying pressure on the open wound and keeping the patient in recumbent position to prevent further bleeding during any movement. Tourniquets, that is, the straps, are used in case of severe bleeding. It is tied above the injury to prevent excessive blood flow to the injured site. Next, to the assessment for heat injury. Heat injury is very common in on-field injury. Especially the heat exhaustion or heat stroke need to be considered as life-threatening conditions. Heat exhaustion is a condition in which player has heavy sweating and rapid pulse as the result of overuse of the body, whereas the heat stroke is the condition caused by overeating as the result of prolonged exposure to physical exertion in high temperature. Heat strokes are more serious than heat exhaustion as it has features like throbbing headache, lack of sweating, and the player may also lose the consciousness. Next subheading is positioning during assessment. Positioning is very important during the assessment to prevent further injuries. Normally, the players is left in the same position in which they are found until the assessment gets over. But when the player is in prone position and has respiratory difficulty, provided the player is conscious, roll the player onto the spinal board with assistance in order to restore the airway. And the recovery position is advised during the assessment if the player is vomiting or has fluid draining from the mouth, provided the breathing is normal. This picture below shows the recovery position that I have been talking about. Moving an injured player from field to out of the field involves sequence like supine lying to sitting with support, then to kneeling with supported in 2 point or 4 point, then to standing with support, and then to standing without support, finally walking off field with assistance. Finally, to the management part of on-field injury. Common management used in on-field injury is riser and no harm. As we know, riser indicates the rest, icing, compression, elevation, and referral. Initially, rest is given to minimize the further damage. Why should rest be given? Rest should be given to reduce blood flow to the injured site. Immediately, icing should be given following the rest because applying ice helps in vasoconstriction, thus reducing the blood flow to the injured site, thereby resulting in less swelling. Then icing should be given every 20 minutes and should not be given directly on the bare skin. Next is the compression. Compression is given with crab bandage or tapes because compression reduces fluid leakage and bleeding over the injured site. Followed by E, elevation, that is elevating the injured site above the level of heart to reduce blood flow to the injured site and to reduce swelling. Finally, after giving rest, icing, compression and elevation, refer the player to the physician or orthopedician for further definitive diagnosis. After the riser, the players are advised to avoid harmful factors for 72 hours after injury to prevent further damage and delayed healing. H refers to heat. Heat should be avoided after injury because it increases blood flow to the injured area, thereby increasing the swelling. This is the reason for applying ice immediately after the injury. A refers to the alcohol. Alcohol is avoided because it increases bleeding and swelling, which results in delayed healing. R refers to running. Further running or any form of exercise results in increased tissue damage due to overload. So running should be avoided for next 72 hours. M refers to the massage, which is avoided during the initial stage of injury as it causes increase in bleeding and swelling, which results in delayed healing. Riser and no arm management is usually indicated to soft tissue injury, and management varies for hard tissue injury and other common injuries. Hard tissue injury management initially includes immobilization and stabilization in the comfortable procedure to prevent further damage, and followed by the riser regime. And the management for skin on-field injury like abrasion, laceration starts with cleaning the part with antiseptic creams and soaps to prevent infection, followed by covering the part with band-aid or cotton, and the ice is applied with the affected limb kept in elevation. Next to the cramps. Cramps are common on-field injury occurred commonly due to dehydration and overuse of tibialis muscle. Management of cramps include relaxation as the first step, then giving stretching and massage to the cramp muscle. Main point in management of cramp is to advise the player to drink sufficient water to stay hydrated. Here are some of the preventive steps of on-field injury. Prevention of sports injury as a main role. Some of the preventions are to have proper warm-up and cool-down, to practice a proper technique, increase the training gradually because sudden increase in frequency or intensity can result in overuse injury. Proper footwear, regular breaks, rest should be given for recovery. Being hydrated by drinking sufficient water, proper intake of nutritional food. These steps helps in prevention of the sports injury. Here are the references which I referred from, and I have also given the link for pocket concussion assessment tool for your reference. Finally, I thank you for your precious time and patience. And I take this opportunity to thank my parents, my HOD, my professors, and my friends, and special mention for the organizer of Young Physio Oratorship contest. I request all the viewers to like, share, and record your valuable comments. Do subscribe for channel Nitin Kumar Arora for further details. Thank you.